Welcome to the February 2024 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach with LACNETS.
Today's presentation is on carcinoid heart disease. A special thank you to our supporters, Ipsen, ITM, Crinetics, and Tercera. LACNET's name stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNET staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNET's founder, Giovanna Joyce Mbezi, and NET patient, Mary Dunleavy, who has been living and thriving with NET for 18 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Now I'm going to hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 300 videos and podcasts. Use our playlist to find webinars on PRRT, liver-directed therapy, clinical trials, imaging, nutrition, and our annual conferences and patient stories. Follow LACNETS on social media. We are on Facebook, X, Instagram with the handle @LACNETS. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
Thank you, Heather. As a NET caregiver myself, I find it's important to stay informed and engaged about the latest in NET treatment and also clinical trials, because we understand that clinical trials pave the way for future treatments. Of course, understanding the various NET clinical trials can sometimes feel daunting. To this end, we created a clinical trials guide, an educational resource that features several key clinical trials for neuroendocrine cancers. You can browse by some of the types of treatments, and when you go to the individual trial page, you will find brief patient-friendly videos and announcements or updates on the progress of the trial. We hope that our clinical trials guide will help you better understand NET clinical trials. It's my pleasure to introduce our speaker for today, Dr. Alan Lewis. Dr. Lewis is a cardiologist at Mayo Clinic, and he manages and treats neuroendocrine tumor patients with carcinoid heart disease. He's one of 3 cardiologists who run the Carcinoid Heart Disease Clinic at Mayo, and they have a multidisciplinary team who meet with the cardiothoracic surgeon and NET medical oncologist quarterly. Dr. Lewis's clinical and research interest is in the imaging and management of patients with carcinoid heart disease, including the use of echocardiography and multimodal cardiac imaging in the investigation and management of patients with carcinoid heart disease. I met Dr. Lewis at the 2023 NANET Symposium in Montreal last fall, where doctors and researchers gathered to discuss the latest in scientific advances in neuroendocrine tumors. I was pleased to see that there were presentations on carcinoid heart disease, a much needed area of awareness and education. And I was so impressed by the way he explained things that I immediately invited him to join LACNETS for an educational webinar. One fun fact about Dr. Lewis is that he is from Auckland, New Zealand, and he went to medical school in Sydney, Australia, and completed his cardiology fellowship in Brisbane, Australia. Dr. Lewis's colleague and LACNETS friend, Dr. Thor Halfdanarson, says of Dr. Lewis, "Alan Lewis is great, a superb clinician and researcher, and I love listening to his Australian and New Zealand accent." Welcome, Dr. Lewis.
Hello, everyone, and welcome to this webinar on carcinoid heart disease. My name is Alan Lewis. I'm a cardiologist who specializes in patients with carcinoid heart disease. Carcinoid heart disease really is my area of interest, both clinically as well as on a research front. And so today, my hope is to walk you through carcinoid heart disease and to really take things step by step. Carcinoid tumors really are very rare tumors. They affect about 1 to 2 people per 100,000 people per year. They are tumors that occur in the gastrointestinal tract. This means the bowels extending anywhere from your food pipe to your stomach to your small bowels, all the way to the very end of the bowels, or from the lungs. And these are the two typical regions that this arises from. These tumors secrete a variety of different hormones. These are chemicals produced by the body, such as serotonin, histamine, tachykinins, kallikreins, and prostaglandins. If we look at the body, you can see that the tumors arise in lung, stomach, bowel, and right through to even the large bowel. These tumors occur typically in the small bowel, and when they're in the small bowel, they secrete a multitude of different hormones. These hormones, to start with, are metabolized by the liver, meaning they don't reach the circulation where your body feels its effect because the liver chews them up. Unfortunately, over time, bits of this tumor can break off and it can go and deposit in the liver, which is called a liver metastasis. When it metastasizes to the liver, it's now able to bypass the liver's destruction of these chemicals. And so these chemicals are now able to reach the entire body, including the heart and the lungs, as well as the rest of the body. And so, really, it is at this point that we start to worry about symptoms. And it's at this point that patients experience symptoms of carcinoid syndrome. And it is at this point that the hormone is available and able to reach the body, that it is able to affect the heart and other organs. So, carcinoid syndrome occurs when these chemicals or hormones are able to reach the bloodstream of the entire body. And it causes symptoms, and these symptoms include flushing, it includes diarrhea, and it includes wheeziness or bronchospasm, and that's noisy breathing when you breathe in or when you breathe out. In certain tumor types, so these are such as bronchial or lung carcinoid tumors, or tumors not arising in the bowel, these tumors can secrete these hormones into your bloodstream without the liver chewing them up and without the presence of metastatic disease or disease that's broken off and gone somewhere else. If we look at a population of patients that have carcinoid syndrome, we know that somewhere between 1 in 2 and 1 in 5 patients with this disease will go on to develop carcinoid heart disease. And carcinoid heart disease really is our area of interest that we're going to discuss in detail today. So let's take a step back and talk about the heart. The heart has 4 chambers and it receives blood from the body. So I'm going to walk us through here. So blood from the body returns to the heart via the 2 big tubes on the left of your screen. They enter the right collecting chamber called the right atrium. And this collects blood from the entire body and allows blood to be pushed to the right ventricle. The right ventricle is an important pumping chamber that pumps blood to your lungs. And so blood from the right ventricle will exit the heart and go to your lungs. In the lungs, the blood receives oxygen and then returns to the left-sided collecting chamber. So that's called the left atrium on the top right here of your screen. It then, from the left atrium, will go through to the left ventricle. And the left ventricle is the big, strong, muscular pumping chamber. And this has the job of pumping blood to the entire body. And it pumps it out through a big tube, which we call the aorta. And you can see the aorta marked there. It goes up and it loops around and it goes down. It has a lot of branches that supply the entire body. Carcinoid heart disease is typically a disease that affects heart valves. And the valves that it affects are those between the right top chamber and the right bottom chamber. So between the right atrium and the right ventricle, you have a valve called the tricuspid valve. And then between the right ventricle and the artery that takes blood to the lungs is another valve called the pulmonary valve. On the left side of the heart, you have the mitral valve between the left atrium and the left ventricle, and the aortic valve between the left ventricle and the aorta. So just to take a moment to talk about these valves, why do we have these valves? These valves are like any other valve that you find in mechanical circuits. These valves are designed to control the flow of blood from one chamber to the other, and they're also important in that they prevent the backflow of blood from one chamber to the other. And so disease of each of these valves can either result in a narrowing, restricting flow, which we call stenosis, or it can result in a backflow of blood, which we call regurgitation or leakiness. So let's talk about carcinoid heart disease here. We talked about those hormones that bypass the liver, and we can see that they act on the valves, particularly on the right side, making your tricuspid valve thicker and making your pulmonary valve thicker as well. These then caused restriction of motion of the leaflets, and we can see that at the end of these disease processes that those leaflets are restricted and not quite able to touch each other, which creates a hole through which blood can leak. Usually we think of these substances as being metabolized or chewed up by the lungs, and so we believe that less of this hormone returns to the left side of the heart. And so because of this, relatively speaking, the mitral and aortic valves are less affected. However, in certain instances, you can have a hole connecting the right top chamber with the left top chamber of the heart, which allows the hormone to bypass the destruction in the lungs and allows the hormone to affect the left-sided valves. And so we do also see disease of the left-sided heart valves, namely the mitral valve and the aortic valve. So we talked about these valves, and so I'd like to show you a few pictures of valves here. These are valves from patients who are affected by carcinoid heart disease. Your valve should be the thickness of a sheet of paper. So if you can imagine a sheet of paper flopping up and down in the breeze, you can think of it as being freely pliable, easily mobile, and able to go backwards and forwards as the blood waves push the blood backwards and forwards. What I would like you to notice on the left side of your screen is that little marker there. That marker marks 1 centimeter, which for those of us who work in inches is about a half inch. And you can see that these valves that should be thin are the thickness of some pretty thick cardboard. And so you can imagine if you took a thick, rigid sheet of cardboard instead of a sheet of paper and now tried to flap it in the breeze, that this cardboard really isn't going to move very well at all. And we can see this thickening on both the tricuspid valve as well as the pulmonary valve, restricting both opening as well as restricting closing. If we look at these valves under the microscope, what we can see is that these valves are not destroyed by the carcinoid. In fact, the carcinoid results in the sticking on of a fibrous plaque. So what do I mean by fibrous? I mean any type of scar tissue. And so you have normal leaflet and then thick scar tissue that is many times thicker than your leaflet, sort of holding your leaflet open or closed and not allowing it to move. And we can see on the image on the left where you can see leaflet labeled, and then you can see my arrows there showing the stuck on plaque that really makes that poor leaflet immobile. On the image on the right, the cusp that is marked there is your normal leaflet, and the carcinoid plaque marked on the right is that thickening and fibrotic scarred tissue that we see over the top of it. We talked earlier about bronchial carcinoid tumors, and we talked about how these tumors occur in the lungs and may bypass metabolism of the hormone by the liver. But interestingly, our group at Mayo Clinic looked at patients with bronchial carcinoid tumors, and we looked at 185 of them. They were about, on average, 67 years of age, slightly more of a female than male. A few had carcinoid syndrome, so about 8% had carcinoid syndrome, and about 10% had liver metastases. But the really interesting thing that we found when we looked at this patient population is that carcinoid heart disease in patients with bronchial carcinoid tumors is quite rare. And if we look at the numbers here, we're looking at a population of 2 out of 185, so that's about 1 in 100 patients. When we looked at these patients, we found one of these two patients had a disease that looks like carcinoid heart disease, which is related to a weight loss drug. And we had another patient that probably had true carcinoid heart disease. They had a hilar carcinoid tumor, they had carcinoid syndrome, they had liver metastases, and they had elevated serotonin or hormone metabolites called 5-HIAA. And so, really, you can see here that out of 185 patients with bronchial carcinoid tumors, one or two patients had true carcinoid heart disease. So it is thought that carcinoid heart disease is relatively rare amongst patients with bronchial carcinoid tumors. So when we look at carcinoid heart disease, as compared to those patients with no carcinoid heart disease, patients have a poorer survival if they have carcinoid heart disease. And so if you're in the majority of patients that don't develop carcinoid heart disease, that's a good thing. But if you have carcinoid heart disease, unfortunately, it is a less good thing. The good news here is that this is a very old paper. This is a paper from 1993, and a number of years have passed since then. And so treatments and prognosis have improved. And so I would tell you to please not read into this in great detail, because my essential message here is purely that carcinoid heart disease is worse than having no carcinoid heart disease. And I'll be talking a little bit more now about how can we improve survival, what can we do with this disease, and how can we treat this the best that it can be. So first of all, I would like to talk about what valves does the carcinoid tumor affect. And we talked about the tricuspid valve between the right top chamber and the right bottom chamber, the pulmonary valve between the right bottom chamber or the right ventricle and the pulmonary artery taking blood to the lungs. We talked next about the mitral valve between the left top chamber and the left bottom chamber, and the aortic valve, which is the last valve in the heart sitting between the left bottom pumping chamber or left ventricle and the aorta. And so we can see that in this patient population, almost everyone that had carcinoid heart disease had involvement of their tricuspid valve, and it was almost universal. The pulmonary valve on the right side was also almost universally affected. There were a few people that had tricuspid valve disease who did not have pulmonary valve disease. On the other hand, we can see mitral and aortic valves occurring after metabolism by the lungs, and those patients really had less mitral valve disease, less aortic valve disease, as we would expect based on that chewing up of these hormones by the lungs. If we look at what the problems with the valves were, we can see here that the tricuspid valve, by and large, was a leaky valve. And so when this disease process happened, the valve sort of scarred down and it became a leaky valve. A few of them had a narrowed and a leaky valve, but it was very unusual to have a narrowed valve for the tricuspid valve. For the pulmonary valve, on the other hand, there tended to be a mixture of leakiness and narrowing, and that was fairly common and fairly expected. And again, when we look at mitral and aortic valves, once again, these tended to cause leakiness of the valve rather than narrowing of the valve. When we talk about valvular involvement, it is interesting to note that the frequency or the commonness with which a valve is involved sort of follows the course of blood as it goes through the heart. Tricuspid valve most frequently involved, then pulmonary valve, then mitral valve, and last but not least, the aortic valve. And so really, it is important to recognize that this is a disease that may affect one valve, but it may also affect other valves, which sort of defines how we deal with this and how we treat with this. The other important thing that I need to point out is that it is really important that doctors look carefully at your pulmonary valve. So it's easy to look at the tricuspid valve. The pulmonary valve is much harder to look at, and often we require a really careful look to make sure that there's no pulmonary valve disease. And at Mayo Clinic, we take extra special care to make sure that we take a great look at the pulmonary valve in this disease process, because you do not want to send a patient to have heart surgery, fix their tricuspid valve, and then find out that the pulmonary valve is diseased and ideally should have been fixed at the same time. So carcinoid heart disease really requires an experienced team that's used to managing patients with carcinoid heart disease. This team really requires that you, the patient, are at the center of this algorithm, but it also requires an experienced oncologist with expertise managing carcinoid tumors, managing carcinoid syndrome, and managing carcinoid heart disease. It requires the cardiologist with a special interest in carcinoid heart disease. It requires us to find a cardiac surgeon with expertise in carcinoid heart disease, and these can be hard to come by because really surgical experience is really important in ensuring good surgical outcomes. And when I highlight that, I'm really highlighting the importance of an experience, not just managing valvular heart disease or congenital heart disease, but really the importance of managing patients on the surgical side with carcinoid heart disease. The other really important person in this algorithm is the cardiac anesthesiologist. Patients may have carcinoid crises during an operation, and it's really important that the anesthesiologist working with the surgeon has experience managing patients with carcinoid heart disease so that they know the interesting quirks that happen in patients with carcinoid heart disease where they may have carcinoid crises and require different management to what they would routinely do in cardiac surgery for management of all non-carcinoid heart disease patients. And so I think the cardiac anesthesiologist with experience in carcinoid heart disease is really an important part of this algorithm as well. And then, of course, other specialists may be required who have an interest in carcinoid heart disease and have expertise in carcinoid heart disease. So what do we do to screen our patients for carcinoid heart disease? All patients with metastatic neuroendocrine tumors that produce serotonin, so neuroendocrine tumors are an umbrella term for a variety of different tumors, including carcinoid tumors. So if you have a carcinoid tumor that's producing serotonin, we should be screening you on a routine basis for carcinoid heart disease. How do we do this? Well, the simplest way of doing this is to do a blood draw and to do a blood test and to measure a chemical in the blood called NT-proBNP. It's relatively easy to do, and it gives us a good amount of information if it is normal. So if the NT-proBNP is less than 260 nanograms per mil, that reassures me that my patient is unlikely to have carcinoid heart disease. On the other hand, if the NT-proBNP is high, that does not tell me that the patient has carcinoid heart disease. It just tells me that this is a patient that I need to have more of a look at. It's a patient that needs further evaluation. And so if the NT-proBNP is elevated, this is a patient that I will then go on to do transthoracic echocardiography, which is an ultrasound of the heart. I will also want to look for a hole in the top chambers between the heart the first time I do transthoracic echocardiography. And the ultrasound of the heart or the echocardiogram will tell me, does this patient not have any disease at all, which is great, in which case we can go back up and do an NT-proBNP, following up with an echo if required. It will highlight a group of patients that don't have carcinoid heart disease, but may have other problems in echocardiography, and they would need to be referred to their cardiologist for evaluation. And most importantly in this group, it will identify a group of patients that do have carcinoid heart disease, and these patients really require referral to cardiologists with expertise managing patients with carcinoid heart disease. So just to reiterate the important things on this slide here, NT-proBNP is useful in screening patients for carcinoid heart disease. However, it is really important to remember that an abnormal result does not mean you need to panic, because it does not necessarily mean that you have carcinoid heart disease. It just means that you don't necessarily not have carcinoid heart disease. So abnormal result means we need to do further assessment and we need to do an echocardiogram to figure out, do you have carcinoid heart disease or do you not have carcinoid heart disease? And so what am I looking for on an echocardiogram? And so I'm going to show you a couple of pictures here of an echocardiogram. And the echocardiogram here, I'm going to show you the tricuspid valve and I'm going to show you the pulmonary valve. What you'll notice here is that you see the tricuspid valve here. And these two things here should be big, long, dangly, floppy things that touch each other. And as you can see, there is a great big black hole in the middle of these two strikingly white, immobile structures there. We also look for flow backwards here, and that flow of blue coming down and to the right of your screen is all severe leakiness of this tricuspid valve here, because that tricuspid valve, as you can see on the picture at the top, never closes. It really never opens any more than it does at the start, and it really never closes. It's the same on the pulmonary valve, but as you can see, beautiful picture of the tricuspid valve on the left. The pulmonary valve is much harder to see, and that's why it's really important to look and look and look and make sure that you see the pulmonary valve well. And this is where an experienced echocardiologist, when you're going to have cardiac surgery, is worth their weight in gold, because they will be able to look, see, and determine is that pulmonary valve working or not. And so you can see here that the pulmonary valve also they're thick and white, they're not very mobile, and I think the color picture is probably most useful here. You can see that flash of blue headed up the screen. Again, not as impressive as the bottom right image there, but once again showing severe pulmonary valve regurgitation in this particular patient, in addition to severe tricuspid valve regurgitation. We talked earlier about identifying a hole between the top chambers of the heart. And so this is something that we do routinely on echocardiography when we have a patient with carcinoid heart disease. And what you'll notice is that the right side of the heart is on the right side of the screen, and the left side of the heart here is on the left side of the screen. What we're doing is we're injecting tiny little microscopic bubbles into the patient's IV line in their arm. And what should happen in this picture here is that the right side of your screen should go white, as it does right now. But the left side of your heart should remain completely without these bubbles. So the left side of your heart should remain as black as it did at the start. Unfortunately, this particular patient has a large hole or a large shunt of blood between the top chambers of the heart, and it is so large that it's enough to make the entire left side of the heart look as white as the right side of the heart does. So this is one of the tricks to be able to identify a hole between the top chambers of the heart. So when we have patients and we identify carcinoid heart disease, what are we going to do next? Do I need heart surgery? Can I be monitored? What do I do? This is a very valid question and a very important question that I'd like to talk about at the moment. So when we look at patients with carcinoid heart disease, we really want to divide up the severity of carcinoid heart disease, because the severity defines what do I do with my patient. If the patient has mild carcinoid heart disease, they're doing very, very well. They don't have any symptoms, and the only reason I know that they have carcinoid heart disease is the fact that I've done an echocardiogram and that was abnormal, or I've done an NT-proBNP and that was abnormal, then I don't need to do anything at this time. We can watch and see. We bring you back every 6 months to look at you clinically, chat with you, find out if there are new symptoms, and repeat your echocardiogram looking for progression. So just to remember, just because you have carcinoid heart disease does not mean that you instantly need cardiac surgery. What it means is that we need to keep a close eye on you, and this disease can progress in as little as 6 months. And so that's why we re-echocardiogram you every 6 months and we reassess you every 6 months. If there are no symptoms and no progression, we may continue doing this for some length of time before we ever have to do anything. And I definitely have patients in this category who I've been watching for years, and we just keep going round and round the circle of mild carcinoid heart disease and reassess them every 6 months. On the other hand, we have patients with moderate and severe carcinoid heart disease. We like to keep a closer eye on them. And so that means that I bring my patients back to clinically assess them and repeat an echocardiogram in them every 3 months the more severe they are, and I may be closer to 6 months if they're less severe. But really, the more severe the disease, the closer the eye you want to keep on your patient. Some of these patients won't have severe valve disease. They will have moderate valve disease. If their moderate valve disease doesn't have any symptoms to go with it, Once again, I'm going to watch them and I'm going to follow them and I'm going to just keep rechecking on them to make sure that they're doing well. If my patient, however, has severe carcinoid heart disease, or if they have symptoms related to carcinoid heart disease, I'm going to scratch my head and think about what do we do next. First of all, your question is going to be, Dr. Lewis, what are symptoms of carcinoid heart disease? And that's a great question. The symptoms of carcinoid heart disease that we typically notice are swelling of the legs. And so the ankles tend to be swollen. And if you push on the ankle, it tends to leave a dent on your ankle. And so that's one of the signs that we see for the retention of fluid and as a symptom of carcinoid heart disease. Other things that we can see are things like you eat your meal, but you really feel like you can't eat much of a meal before you're full. It's a symptom that we call early satiety or feeling full early. You may have swelling in the belly, and the best way to describe that is the belly looks a little pregnant looking. It sort of doesn't look like fat, but it looks more pregnant looking where the belly is distended and has a certain contour to it. So swelling or fluid in the abdomen is another thing that we look for. Occasionally, people may describe shortness of breath as their first symptom, but more commonly, it is the swelling in the leg, swollen belly, finding that they're satisfied by their meal fairly early on, which are the early symptoms of carcinoid heart disease and which we would do further investigation for. If a patient does have truly severe carcinoid heart disease, what we want to really do is to figure out the tumor status. What can we do to manage the tumor? How can we manage that best? And we need to see how fit and well you are, because one of the things we're going to think about is, are we going to be able to perform cardiac surgery? So the fitter and more well you are, the more likely you are to be able to tolerate heart surgery and recover well from heart surgery. So that's another important consideration, which we'll talk about in a few slides here. And then the thing that we do at this point is to consider surgical intervention. Remember what I mentioned earlier. You really, if you're considering surgical intervention, want a cardiac surgeon who is experienced in the management of carcinoid heart disease, a cardiac anesthesiologist, and a cardiologist, again, with expertise in managing carcinoid heart disease particularly. And so, when do we operate on patients with severe valvular disease? So, if you have mild or moderate disease, generally in most valvular diseases, they tend to be well tolerated and they tend not to have symptoms. Even patients with severe symptoms may be watched for a length of time. So, just because the word severe is on your echo report does not mean that you instantly need valve surgery. And so, you will find that some of us will watch you even with severe valve disease, not because we're procrastinating or delaying, but because it is reasonable and safe to do so until we reach a certain point. And so that's why we choose to watch and see, even in severe valve disease, until patients meet additional criteria. One of the big criteria in my mind for all forms of valvular heart disease is the presence of symptoms. So if you walk into my room and you tell me, Dr. Lewis, I've got these swollen legs. I can't eat anything. My abdomen or my belly is swollen. Then I'm going to be scratching my head and going, well, let's try a little bit of fluid tablet. But the reality is, I'm going to be thinking that that's not really going to work. And let's send you to see the heart surgeon at that point. So symptoms really are a big thing that make me think we need to fix the valves here. And this is true for the tricuspid valve as well as the left-sided valves as well. Because the tricuspid and pulmonary valves are most frequently involved, I've listed the criteria that I look at in terms of needing cardiac surgery for the right-sided valves here. And then we'll talk about the left-sided valves here in just a moment. But the right-sided valves tend to cause dilation or enlargement of the right ventricle, that with the right bottom pumping chamber that pumps blood over to the lungs. And it looks for dysfunction or the fact that the right ventricle is not working. And if we see those and those are getting worse, that's an indication to us that the heart is not tolerating the disease in the valves and needs to be fixed. In some patients who don't have symptoms, but who are planned to undergo liver surgery, we would consider replacing their valve. And that the reason for this is if your tricuspid valve is leaky, it puts a lot of back pressure on the liver. And the liver surgeons worry about bleeding at the time of liver surgery. And so we have definitely done a few of these where we have operated in patients that didn't have symptoms but had severe valve disease before they could have liver surgery. And so that's another reason that we think about, which is unique to my carcinoid heart disease population. And then for the other valves, we follow the usual American College of Cardiology and American Heart Association national guidelines for the indications for valvular disease. And these include particularly symptoms across all valvular disease types, but also different measurements of the left bottom pumping chamber, which help determine need for surgery, as well as the pumping function of the left bottom chamber or left ventricle. So we talked about this a little bit earlier, and the importance of looking at you as a whole, the importance of looking and seeing, is cardiac surgery the right thing? Because I think it is important to remember that our goal when we do cardiac surgery is to improve your quality of life. Cardiac surgery is a big deal. It is an operation, it's a major operation. And as with all major operations, it does have a recovery time. And so my big goal when I see anyone is to see, are they fit enough to have cardiac surgery? Because the last thing I want to do is to send someone to cardiac surgery, but their rehabilitation after surgery to be so difficult that they're not able to rehabilitate back to the level that they were at before I sent them to cardiac surgery. And so factors that we consider or factors that we looked at that show that the prognosis or that the outcomes are worse in terms of survival include things such as age. Obviously, the older you are, the harder it is for you to recover. And there is no age cutoff for surgery, but it's one of the factors that probably tells us what is the person's likelihood of recovery. The more frail you are, as denoted by your age, the less likely you are to get back to where you were when you started. But saying that, if you're fit and strong, regardless of age, and you look really good and you feel really good, that doesn't stop us from offering you an operation. Another thing we noticed, again, another marker of sickness going into an operation, the more short of breath you are, the more unwell you are. This is the second line here called NYHA class that I've highlighted. The worse you are to start with, the less good your long-term outcome. So if you're so short of breath that you're short of breath just sitting on your chair, it is more challenging to get you back on your feet than if you're short of breath but you're doing a fair amount of exertion. And the last important point that we think about in terms of outcomes is the blood test called creatinine. And this is important because this tells us what is your kidney function. And the kidney function plays a big role in terms of recovery from cardiac surgery. And in this particular study that we did here at Mayo Clinic, we can see that the highlighted features that I've highlighted were the three important ones that wound up being significant in the study. All the other factors listed were things that we looked at, but things that were not significant or not important. And so that's why I highlight and I stress just these three lines, because these are the three lines that I think are important outcomes as a result of our study. So the other thing that we want to look at is the choice of valve prostheses. There are different types of valves that are available for use. They include mechanical valves and biological valves. Mechanical valves are essentially two sheets of metal or plastic that open and close. They are not biological material. On the other hand, biological valves are pig or cow tissue that have been designed into a valve. And so they function a little bit more, or they behave in the body a little bit more like normal biological tissue. Unfortunately, the advantages of one valve type are the disadvantages of another valve type. And so in our patients, when we generally think about a mechanical valve, we generally think that those patients will need a blood thinner for their valves in the long term, meaning lifelong. The medication we use is a medication called warfarin or Coumadin, and the idea of that is that that helps prevent clot formation on these mechanical valves. On the other hand, biological valves have the advantage of not needing a blood thinner for the actual valve. Now, if you have another reason, an irregular heart rhythm, a clot in the leg, or something else that gives you a reason for having a blood thinner, then having a biological valve does not take away that reason for the blood thinner. But really, the biological valve here has the advantage of not needing a blood thinner in the long term necessarily. On the flip side, traditionally speaking, we think that the mechanical valves will last longer than the biological valves. And so, in the early days of our experience in managing patients with carcinoid heart disease, we worried about the durability of biological valves. And so, we had a tendency to place mechanical valves at that stage. And this is work that I'd done with my friend and mentor, Dr. Connolly, here at Mayo Clinic. And we had looked at our data and looked at patients that had biological valves and mechanical valves. And interestingly, in this particular study, we found that those patients that had biological valves did equally as well as those people that had mechanical valves. And both valve types seemed to be equally as durable or long lasting. And so, in general, particularly for the right side of valves, biological valve tissue may be preferable due to a higher risk of clotting on the right sided valves as compared with the mechanical valves on the right side. And so there has probably been a bit of a swing in the clinical practice to consider using more biological valves while remembering that both valve types are reasonable to do. The other thing that the work from Dr. Connolly and myself showed is the fact that biological valves, although there were concerns that these develop carcinoid plaques and will develop carcinoid heart disease, among the 7 biological valves that we took out of patients at the time that they needed cardiac surgery, none of these 7 valves that we removed had any evidence of carcinoid heart disease involving the valve that was prosthesis that was placed. And so that was really very reassuring because the traditional concern had always been that we're going to place a biological valve. And unfortunately, these biological valves are going to get carcinoid on them. And then we're going to be stuck going back to step 1 all over again. So the reassuring news in the study is that the bioprostheses that we used and studied in this particular study did not seem to develop carcinoid when we looked at them and had our pathologist looked at them under the microscope. One of the interesting things that we did find in these biological valves, though, however, is that some of these biological valves, this is the 4 patients in the top right, developed clot on their biological valve. And so their valve was damaged by clot rather than carcinoid plaques. And so one of the things that I really keep a high awareness of in my patients that have had biological valves for carcinoid heart disease is the risk of clot formation on a biological valve, even though the desire of placing a biological valve is potentially to avoid the need for a blood thinner. In these patients, I pay very close attention to their echocardiogram, looking for any inkling of clot. And if there is evidence of clot on a biological valve, unfortunately, we have to put the patient back on a blood thinner, namely warfarin or Coumadin. And yes, that is unfortunate, but at the same time, we believe that it will preserve the function of the valve and avoid the need for another operation. So it is really important if there is clot on a valve that we've placed that we consider giving a blood thinner to manage this. This risk is reasonable. I don't think it's astronomically high, but I tell all my patients with carcinoid heart disease of this because they definitely represent an at-risk group of patients with biological valves and having a clot on a biological valve. Because we generally think of biological valve clots as unusual, but I have noticed that it is more common in our carcinoid heart disease population. The other advantage of placing a biological valve in our patients with carcinoid heart disease is that the mechanical valves in the tricuspid valve position do have a high risk of clot formation on the valve. And so, because of that, we worry when we have to stop blood thinners for procedures and things like that. And sometimes, if you need to have a procedure on your liver or other procedures related to your carcinoid, it makes us very nervous with right sided mechanical valves. Whereas, even if you've had a history of clot formation on a biological valve, we feel a little bit more reassured of the safety of withdrawing blood thinners for the purpose of your procedure and restarting them straight afterwards. So I think, for that reason, despite the need or risk for a blood thinner in the longer term, despite choosing a biological valve, I have tended to favor biological valves in my carcinoid heart disease population. So I've said a lot so far, and I'm going to stop and try to summarize what I just said. I think the important things that I want you to take away from this is that carcinoid heart disease is extremely common. It affects 1 in 5, up to even 1 in 2 patients with carcinoid syndrome. And so, because of this, it is really important that all patients with carcinoid syndrome are screened for carcinoid heart disease. And this screening needs to happen regularly and frequently. And we talked about this happening every 6 months. And our options for screening include blood testing with an NT-proBNP, as well as echocardiography or an ultrasound of your heart. The second point that I would like to make is that surgical valve replacement can improve survival. And it is really important that this is done in the hands of an experienced team, not just experienced in the management of valvular heart disease, not just experienced in the management of congenital heart disease, but very, very importantly, managed at the hands of a surgeon that has experience with carcinoid heart disease and an anesthesiologist that has experience in carcinoid heart disease. And the last point that I'll leave you with is that it is very important that we have careful discussions about what valve type to choose, because both tissue valves and mechanical valves may have comparable outcomes based on the study that we had performed here at Mayo Clinic. And so I think recognizing that there is a choice between a tissue valve prosthesis and a mechanical valve prosthesis is important, and slowly walking through what is important in your particular health situation and figuring out what will guide us to choice of the right valve in you is very, very important. And both valve types are definitely on the table, be it mechanical or biological. And so with that, I would like to conclude. I'd like to thank you all for your attention and listening to this discussion on carcinoid heart disease. And I'm going to welcome all of you to ask questions, and I'm going to do my best to answer your questions as best as I can. Thank you very much for that.
Thank you, Dr. Lewis, for this fantastic overview on carcinoid heart disease. I agree with Dr. Thorhab-Dennison that it's a pleasure listening to this potentially difficult content with your Australian and New Zealand accent. And as you know, I mentioned to you when we invited you to this educational event that several people in our community have carcinoid heart disease, including several who have had surgery valve replacements due to carcinoid heart disease. And we're really excited to have you here with us today to give us a presentation and answer many questions. Welcome.
Thank you very much, Lisa, for the opportunity, and I'm glad to answer whatever questions you guys have.
Well, just as a reminder to the audience, this question and answer session is for educational purposes only. It does not substitute for medical advice. Please talk to your medical team with your own concerns and questions about your individual care and treatment. And we have many questions rolling in. We have over 35 questions, so it's not possible to get to them all. We will try to get to as many general questions as possible. So with that, let's start with the first one. And I know this one you covered at the very beginning of the presentation, but just to reiterate again, how common is carcinoid heart disease in those with carcinoid syndrome?
So carcinoid heart disease is incredibly common in those people with carcinoid syndrome. The data suggests somewhere between 20 and 50%. And to put that into perspective, that means 1 in 2 to 1 in 5. So really incredibly common.
That is perhaps even more than we think. And on the flip side, for those who do not have carcinoid syndrome, should they be getting screening for carcinoid heart disease? And then there's follow-up questions. What if the NET is functioning but not producing serotonin? And then what if it's not functioning?
That really does cover the whole spectrum there. So in terms of the guidelines, generally speaking, the guidelines generally say to screen those patients with carcinoid syndrome who have functional tumors and it's secreting hormone. And so those are really the main target group for screening patients with carcinoid heart disease. If we look at non-functional tumors, we will always have occasional cases or case reports of patients having carcinoid heart disease. And, it's really hard to figure out, do we screen an entire population looking for that? Or do we target, and who do we target? And so that is an incredibly difficult question. I think one of the important things is that when we see you in the oncology clinic for regular follow-up, to carefully examine you, carefully listen to your heart, carefully look at your neck veins and things like that. And certainly a case could be made for doing that screening blood test called the NT-proBNP that we spoke about earlier from time to time, given its simplicity, given the fact that it could be done with the remainder of your blood test and things like that. And generally speaking, we expect those people with functional tumors to have this disease process. And generally, while we believe it's the serotonin that's the cause of all of this, we don't definitely know which of the hormones it is. And so if it's a functional tumor and it's not secreting serotonin, we think that likelihood is less, but definitely at this stage, we don't know definitely which of the multitude of hormones that the carcinoid tumors secrete is actually the culprit for causing your carcinoid heart disease.
Well, thank you for that. I think that does address a multitude of questions that are in the audience. So thank you. There are several questions surrounding somatostatin analogs. So can long-term use of lanreotide or any somatostatin analog cause atrial fibrillation or other heart issues? And can an atrial fibrillation diagnosis in NET patients point to carcinoid heart disease?
So this is really a difficult question here because, you're really trying to prove a link between two different conditions. And the difficulty here is atrial fibrillation, for those of you who haven't heard of this, is basically an irregular heart rhythm caused by various different spots in the atrium all firing off at the same time, rather than the normal coordinated contraction caused by one spot in the atrium firing off, causing the top chambers of the heart to squeeze. We know that the risk of atrial fibrillation rises as the top chambers of the heart get dilated or get bigger. And we know that one of the causes for heart chamber dilatation is leakiness of the tricuspid and mitral valves. And so when we have patients with carcinoid heart disease, these patients are susceptible to increasing and massive increases in the top chambers of the heart. And so that really predisposes to atrial fibrillation. So trying to tease out, is it the lanreotide or is it the tricuspid valve regurgitation that's causing the atrial fibrillation is really incredibly challenging. And I don't think anyone would ever have the answer to that particular question. I think the important thing when we think about all forms of treatment is, are we putting you on the right treatment to treat the problem that we're trying to treat? And in carcinoid syndrome, when we're trying to limit the amount of circulating hormone and the amount of circulating symptoms resulting from those circulating hormones, these are really the right agents to use. And so I think we have to understand, even though there may be a risk of atrial fibrillation, and the prescription information doesn't necessarily list atrial fibrillation as a potential risk factor, but even if there were to be a risk, we still need to treat the underlying condition overall. And in answer to the second part of the question about could atrial fibrillation diagnosis point out a diagnosis of carcinoid heart disease, as I mentioned earlier, the top chambers of the heart are dilated as a predisposing factor. So yes, certainly in my patients that have neuroendocrine tumors and have atrial fibrillation, I would think that those patients need an echocardiogram to assess their valves and exclude carcinoid heart disease. So yes, I would view atrial fibrillation as potentially pointing to a diagnosis of carcinoid heart disease.
Thank you. And that actually answers a couple other people who asked the same question about atrial fibrillation and carcinoid heart disease. There was another related to that. Can NETs cause atrial fibrillation? And if a person has metastasized small intestinal NETs and atrial fibrillation, what are the pros and cons of catheter ablation, rhythm drugs, and rate control drugs?
These are really questions to be tailored to the personal individual, because it really depends on where the disease process is. Now, we have some patients with carcinoid tumors who really have no carcinoid heart disease whatsoever. And in those patients, you would treat them like any other person that you treat with atrial fibrillation. In atrial fibrillation, we think about symptoms. How symptomatic is my patient? How important is it that they're in the right rhythm? Because the answer for every patient isn't necessarily that they have to be out of atrial fibrillation to do well. We would put patients with atrial fibrillation on a blood thinner, and that blood thinner would apply regardless of whether we think people are in atrial fibrillation or not. Namely, if we're trying to keep people in the right rhythm, it still doesn't get rid of the need for a blood thinner in management of those patients. And so really, it's a really specific, depending on the person, type approach. If you have severely leaky valves, then a catheter ablation is unlikely to be able to get control of your heart rhythm because of that stretch on those top chambers of the heart. And so, generally speaking, in someone that's got severe tricuspid valve regurgitation or severe mitral valve regurgitation, and I'm trying to control their atrial fibrillation, I would think that atrial fibrillation ablation would not be likely to have a high success rate. And so, in those patients, I may send them to cardiac surgery, tell the cardiac surgeon to replace the valve that needs to be replaced. And at the same time, the surgeon can do an ablation or what's called a maze procedure during the surgical operation. And so really, it's a very nuanced discussion, which really depends on what does the person's disease, what are their symptoms, and what is the right approach in them. In terms of thinking of catheter ablation overall, myself and my colleagues at Mayo Clinic did have a look at our outcomes after cardiac ablation procedures for things such as atrial fibrillation, and we, generally speaking, found it safe to perform these with an appropriately trained team and appropriate anesthesia support, and an understanding that patients with carcinoid tumors may have carcinoid syndrome and may have carcinoid crises, and having the available drugs available in the room to treat the patient if such a thing eventuates. So I think there's nothing wrong with doing cardiac ablation in my carcinoid heart disease population patients, but at the same time, determining, as I would in any other patient, is it the right choice or not?
Mm-hmm. Yeah, it sounds like a complex decision and requiring a multidisciplinary team for sure.
Absolutely.
Well, we touched on lanreotide or octreotide, somatostatin analogs. Is there one that's more effective in treating carcinoid heart disease?
So I generally believe that we use both of them with equal effectiveness here. And so I don't generally have a preference for one over the other. The reality here is the decision on these medications are generally made by my oncology colleagues, and they really are the experts in these choices of medications. And so because of that, I let them make these choices, and then we go from there. In terms of treating carcinoid heart disease per se, we believe that these agents may be associated with a reduced risk of carcinoid heart disease or reduced progression of carcinoid heart disease, but neither of these agents per se would reverse the disease in someone that has a diagnosis of carcinoid heart disease.
Okay, thank you. Thank you for that. So I know there's been other questions about, can this be related to carcinoid heart disease? Can carcinoid heart disease be misdiagnosed as congestive heart failure?
So that's a great question. Congestive heart failure really is a very broad term. It's a broad term for anyone that has fluid on their lungs as a result of back pressure of blood on the lungs. And it can be also anyone that has a right side of their heart that doesn't function well, again, resulting in back pressure on the rest of the body with fluid retention on the rest of the body. So, really, congestive heart failure is part of the spectrum of carcinoid heart disease in that you're retaining fluid. And the reason in carcinoid heart disease that you're retaining fluid is really the fact that you have valves that don't work well. And so, yes, in someone that has symptoms of congestive cardiac failure, they may have carcinoid heart disease and should have an echocardiogram to evaluate that. In saying that, we also have patients with congestive heart failure who do not have carcinoid heart disease, and they may have the congestive heart failure for other reasons. But my first go-to is to make sure they don't have carcinoid heart disease. If they don't have carcinoid heart disease, to then evaluate for the other causes.
Okay, thank you. Thanks for clarifying. Can carcinoid syndrome-related increase in norepinephrine that causes a rapid increase in heartbeat be related to or symptomatic of carcinoid heart disease?
So Everything in the body is interrelated. These hormones secrete a multitude of different hormones, and these hormones can push up the heart rate. As well as that, my carcinoid tumor patients are on various treatments, and some of them even on chemotherapeutic agents, and this increases the body's demand for energy and blood flow, and so that can push up your heart rate as well. And we talked about atrial fibrillation as well, that irregular heart rhythm that happens from time to time, again, can cause a rapid heart rate. And so a rapid heart rate per se in itself doesn't tell me the person has carcinoid heart disease. But it's definitely something to look into, and it really depends on everything else that's going on at the same time.
Thanks. And actually, related to that, someone else asked about rapid heart disease, if it's a sign of carcinoid heart disease, and also does an elevated chromogranin level cause rapid heart rate or is an indication of carcinoid heart disease?
Again, very similar answer here, Lisa, that, the rapid heart rates may be a manifestation of carcinoid heart disease, but really there is no proof that that's the cause because of the multitude of different things going on in the body, the multitude of different treatments and things like that going on. And the chromogranin level here, again, like the norepinephrine, may or may not cause a rapid heart rate here. And, really the chromogranin A, if it's elevated, does indicate that you have an elevated serotonin level and things like that. And so patients with high chromogranin levels, independent of heart rate, that may be a predisposing factor to future development of carcinoid heart disease and a marker of disease severity.
Thank you. Someone actually asked this question, which reminds us to kind of take a step backwards. In general, what are the symptoms of carcinoid syndrome, and why do some NET patients have it?
Some neuroendocrine tumor patients have tumors that secrete hormones, and the hormones we spoke about earlier really are important. They're things like serotonin, histamines, kallikreins, we have norepinephrine, and a variety of these different hormones. Some of these hormones act on blood vessels, and those hormones cause the symptoms. So if you have a patient that has a neuroendocrine tumor that isn't secreting those hormones that cause the blood vessels to dilate or have a great action on blood vessels, then they may not have these symptoms. But in patients with neuroendocrine tumors that have the right hormones, they get carcinoid syndrome. And carcinoid syndrome really is a variety of different symptoms. The ones that we think of most commonly are diarrhea. They get facial flushing. They may have a wheeze as well to go with it. That's that noisy breathing that we spoke about earlier in the presentation.
Thank you. Thanks for clarifying. And what about lung nets? Does a lung net secreting ACTH affect someone with a prior heart attack?
When we looked at our neuroendocrine tumor patients that had bronchial carcinoid, it was a limited number of patients. They didn't seem to get carcinoid heart disease. And when we talk about heart attacks, we're talking about coronary artery disease. These are blockages in blood vessels. And we really, when we looked at that data, didn't see an excess or an increase in the number of patients that had heart attacks in that population.
Thank you. And, this is a question about treatment and what's okay. Is it okay to take baby aspirin for your heart if you have extensive liver metastasis?
Generally speaking, we use baby aspirin in our patients with heart disease that have carcinoid heart disease without any problems. When we replace valves, even though patients have extensive liver metastases, we're often putting them on more potent blood thinners like warfarin and Coumadin, and bleeding really hasn't been a big issue with this. I think, everything that we do is done in consultation with our oncology colleagues and the other people treating the particular patient. And so I think that's really important to have a collaborative stance with people. And then the other thing is, if patients are going to have procedures, talking to the surgeon or the interventional radiologist or our colleague that's going to do the procedure in terms of if they would want the aspirin stopped for a procedure. And generally speaking, cardiologists love baby aspirin, and so we would think that it's tolerable to do most procedures on baby aspirin, but there are certain sites at which the bleeding risk is intolerably high, And we work with the surgeons or we work with the oncologist to make sure that the right choice for you is what's being implemented. But as a general answer, baby aspirin is fine even in patients with extensive liver metastases, unless they've had a complication from that previously.
Thank you. Thank you for that. And we're going to move into some questions about valves as well. Is there a connection between carcinoid syndrome and calcium deposits in the coronary arteries and aortic heart valve?
We don't believe that the two are related because carcinoid syndrome tends to result in this fibrosis or thickening of valvular tissue. And so it really causes a thickening. And this thickening, generally speaking, doesn't have a lot of calcium in it. Now, the calcium that we see in valves and the calcium that we see in coronary arteries is a routine part of the aging process. And so when we look at aortic valves that don't work, really, and we look at the general population, it tends to be calcium that has affected the valve and caused it to degenerate and not move as well as it should. But generally speaking, our carcinoid heart disease patient population, we're looking more for the thickening and scarring, which generally occurs without calcium related to this disease process, even though it's possible that both exist because the aging process unfortunately occurs in all of us at all times.
Yeah, thank you. Thanks for that. And how frequently does carcinoid heart disease affect the aortic valve?
So carcinoid heart disease affects the aortic valve relatively rarely. It tends to, as we talked about, almost universally affect the right-sided valves. On the left side, it's relatively rare to affect the mitral and aortic valve, and the aortic valve is the least likely of the four valves to be affected.
Okay. Is it atypical and worrisome to have leaks in your mitral or tricuspid valves?
That's an excellent question to ask because I think, in this day and age, everyone has access to the electronic medical record. Everyone can read their echocardiogram reports, and everyone, unfortunately, without the right training, can overread into their reports. And so I think we need to recognize that the way we were built is that these valves normally have some amount of leakiness across these valves. When I work in the echo lab, it's not uncommon to see mild leaks in the mitral and the tricuspid valves. And so the reality here is that while we technically say that a trivial leak in the valve is normal, mild leaks are not uncommon and don't necessarily indicate that you have carcinoid heart disease. And so if we're looking at moderate or severe leaks, then those are patients I want to monitor, and those are patients that I want to be more watchful of. And the mild leaks we may monitor, but we monitor less frequently. So really, there are some where there is a trivial leak and that's normal. Mild may even be within the spectrum of normal. But as we get more and more severe, then we have to be more and more watchful.
Yeah, thanks. That's a really good point that we have access and just to look at the level of leakage. If the tricuspid valve has moderate or severe regurgitation and pulmonic has mild regurgitation, and if surgery is needed to replace the tricuspid, should both right-sided valves be replaced?
Great question. Now, I'm going to bring you back to the fact that the pulmonary valve is really, really hard to see. And so the pulmonary valve often is where I find is the Achilles heel of this whole thing. And the pulmonary valve regurgitation severity can be underestimated by people that are not expert at looking at the pulmonary valve. So I would say pulmonary valve should be looked at very, very carefully. And not just by looking at the color, but there are other things that we look on the echo, which is a graph-like thing that we call spectral Doppler with continuous wave Doppler. And so that graph really gives me a lot of information in my patients with carcinoid heart disease, because some of the time that is the only sign that there is a lot of pulmonary valve regurgitation. So that's, my sidetrack here to tell you the pulmonary valve is difficult and needs to be looked at really by an expert that knows what they're looking at. If, in fact, pulmonary valve regurgitation is mild and the tricuspid valve needs replacement, remember what I said earlier about the fact that our valves have some leak in it normally. And so if the leak is truly mild, the valve looks normal and doesn't look like it's involved by carcinoid heart disease, then it is very reasonable to replace the tricuspid valve without replacement of the pulmonary valve. So it's not mandatory for a mild leak of the pulmonary valve that we need to replace the pulmonary valve. And we try to replace only what's needed, because otherwise you increase cardiac surgical risk. And the other thing is, if you replace something, everything man-made has some amount of life to it. And so determining what is that life of a valve that I replace versus what is the life of the original part or the original pulmonary valve. And so we don't want to put something in that has a shorter life than the original valve that went in.
Could you repeat again the enhanced imaging that you were talking about to really get a good look at the pulmonary valve?
And so this is really routine imaging, and it's done routinely, and it really requires the interpretation of this, but it's called continuous wave Doppler of the pulmonary valve. It's done routinely. It's the question of knowing, recognizing, and understanding what that signal shows you that's really important.
Okay, that is routine, so it's not something a patient has to ask extra for.
It is fairly routine. The labs all vary a little bit from place to place. The patient is definitely welcome to write that down and ask to make sure it was done. I think there's always a level of safety because there is variation around the country and around the world. But at Mayo Clinic, we would do that routinely across your pulmonary valve on any echocardiogram that I read.
Thank you. So you mentioned the different types of valves, and that was really, really helpful. So if someone has, say, a family member of mine had a tricuspid valve replaced with a PIG valve due to carcinoid heart disease, but then within 2 years it begins to fail, what would you recommend doing?
That's a great question. And I think the difficulty here is over time, we haven't recognized the fact that these valves have a risk of valve clot forming on it or valve thrombosis. And I think that these can be fairly subtle when we look at these valves. And the reality is, over the last 10 or 20 years, we've started to recognize that biological valves can get clot formation on top of them. What I find is really important is, particularly in a carcinoid heart disease population, looking at those valves really carefully for the possibility of development of clot. And if there is a suspicion, to evaluate further and to have a low threshold for putting people on a blood thinner. And the blood thinner that I usually use is that medication, warfarin or Coumadin. And so I think, often we fail to recognize it. And if we fail to recognize it, then the valve degenerates much quicker than in other cases. Even if you watch meticulously, this is a risk and it does happen. And I do talk to my patients about it. When valves fail early, the question really is what to do next. And it really boils down to going back and thinking about things from the very beginning. Remembering that my reasons for sending someone to a tricuspid valve operation are really, does my patient have symptoms? If the patient has symptoms, then we would have to think about what do we do to the valve. However, if the patient doesn't have symptoms and the right side of the heart is working well and there is no signs that the right side of the heart is tolerating this poorly, it may be reasonable to wait and see until they develop symptoms before we do something about it. When we do something about it, we have choices for what we can do about it. One of the choices is to open the chest or reopen the chest here, remove this failed bioprosthesis, and then replace it at that time. And then the discussion starts all over again about whether we choose a biological valve or a mechanical valve. On the other hand, some of these valves, depending on size and type, can also be replaced through the groin. And so we can do a percutaneous transcatheter valve in a tricuspid valve position to salvage the situation. Think after we do a procedure, if we choose a biological valve, it is very important to recognize that this valve has probably failed because of clot on the valve. And so because of that, it is really important that we strongly consider blood thinners lifelong for that person in the long term. And so I would go out of my way to check if I think that this is clot or not, and I would have a low threshold, even if I choose a biological valve, for keeping them on a blood thinner lifelong. The other question that will be on your mind is, if you're going to replace my valve with a biological valve and tell me you're going to give me a blood thinner and you're not doing this through my groin, why not put a mechanical valve? And that's a great question. We scratch our heads. and think carefully about it, because unfortunately, mechanical valves on the right side of the heart as opposed to the left side of the heart have a much higher risk of clotting in that position, and because the blood flow is not as vigorous as it is over on the left side of the heart. So it brings with it its own set of problems. The issue also winds up being with the mechanical valve in the tricuspid valve position. If you're going to have a procedure, we really have to be meticulous about making sure that you have blood thinners on board for those procedures. So that's why I say we go back to the drawing board and talk completely again about risks versus benefits. We talk to oncology, we talk to the patient, we talk to the other people managing the patient to really come down to what is the right decision choice here.
Thank you. Thank you for that very thorough answer. And you also answered another question about how to prolong the life of the valve. So there's this other question about how can carcinoid heart disease differ or present in someone with patent foramen ovale? And if you could just remind us what that is as well.
Absolutely. So patent foramen ovale is a hole that connects the left top chamber and right top chamber of the heart. Because before we are born, we don't want all the blood going to the lungs, because lungs would chew up all the oxygen and the rest of you really wouldn't grow. So before we are born, we have this connection between the right top chamber and the left top chamber, which allows blood to bypass the lungs and supply the remainder of the body, and really to allow the rest of the body to grow with the oxygenated blood from the mother. And so a patent foramen ovale is when this hole between the top chambers of the heart does not close. A patent foramen ovale is incredibly common. 1 in 4 to 1 in 5 of us has this. And so I find it hard to call it an abnormality, because really it is probably a normal variant. And if you had a patent foramen ovale in a normal person without any other medical problems, we really don't have a reason to go and close this thing. But in patients with carcinoid heart disease, a patent foramen ovale increases the risk of left-sided valve disease. So when I talk about left-sided valve disease, I'm talking about carcinoid heart disease affecting the mitral and aortic valves. And so because of that increased risk of valve disease on the left side, we watch the left-sided valves more closely. And at the time of cardiac surgery, we would close the patent foramen ovale. I say at the time of cardiac surgery because that's the time at which we usually do it. And the procedure is relatively easy for a surgeon to do if they're already in there fixing a tricuspid valve. It really involves 1 or 2 stitches and literally takes, 60 seconds to do or so.
Yeah, wow, thank you. Thanks for that. What about murmurs? So is a newly discovered murmur suspicious for carcinoid heart disease? And also, is left ventricular hypertrophy suggestive of carcinoid heart disease?
Great question. So we'll take the murmur question first. So let's start with what is a murmur. A murmur is a noise generated by turbulence of blood flow as it traverses from one chamber to another. When we're children, murmurs can just occur due to normal flow, but as we get older, generally murmurs indicate abnormal flow. The most common place for this turbulent blood flow is when blood is going backwards or reduced flow forward. So a narrowing in the valve or a leaky valve are the common reasons for a murmur. And so because of that, I would say that the murmur that's heard may be a sign of that regurgitation or stenosis across the valve. And so that murmur, yes, absolutely may be a sign of carcinoid heart disease. And in those people, I would get an echocardiogram to evaluate them further. The left ventricular hypertrophy or the thickening of the left ventricular muscle is a different question. And it's definitely a challenge to answer that, because left ventricular hypertrophy can happen due to a number of different reasons. By and large, I do not think of left ventricular hypertrophy and carcinoid heart disease being related. Generally speaking, to discover left ventricular hypertrophy, you would have had to have an echocardiogram to look at it. And so you may have the answer there already because you have the valves on the same screen. If this is left ventricular hypertrophy as diagnosed by an ECG, usually, an echocardiogram would be a reasonable next test to evaluate that. And I think we have to appreciate that the most common cause of left ventricular hypertrophy is probably going to be high blood pressure more than anything else, especially if it's just a little bit on the thick side, unless you have a genetic condition that predisposes you to abnormalities that cause left ventricular hypertrophy or other diseases, processes that predispose you to left ventricular hypertrophy. So
Thank you. Thank you for those informative answers. What about a narrow pulse pressure? Is that indicative of carcinoid heart disease?
another good question. And so, what is a narrow pulse pressure? A narrow pulse pressure is a small difference between your top and bottom number for your blood pressure. Usually, when we think of carcinoid heart disease, we're thinking of a leaky aortic valve. Again, we talked about that earlier as being the least likely of all the valves. And so, generally speaking, we're looking at broader or widened pulse pressure as a sign for severe aortic valve regurgitation. Generally speaking, I don't hang too much weight on a narrow pulse pressure for making the diagnosis for anything at all.
Thank you. Let's talk about some of the treatments. What's the role of telotrestat or Zermelo in carcinoid heart disease management or prevention?
Well, that's a great question and one that's completely unanswered. There is a clinical trial going on at the moment to look at the effect of telotrestat on carcinoid heart disease management and prevention. And so, really, unfortunately, we need to wait for the results of that study to know whether it will be effective or not be effective. And this is one of the things I'm really looking forward to seeing the results of, because I think, if this does work in this disease population, I think it could be very exciting.
Yeah. And along the lines of prevention, can carcinoid heart disease be prevented and how can it be caught early?
So, I think really progression of disease can be controlled by good control of the underlying disease and by good control of the underlying carcinoid syndrome. There is nothing we can do that will guarantee that you won't develop carcinoid heart disease, but having an oncologist that's experienced in disease management, an oncologist that can really treat the disease well, is our best bet for avoiding carcinoid heart disease.
Yeah. And speaking of, there were a couple questions along this line of how do I find a local cardiologist who is an expert on carcinoid heart disease?
That's a great question. This is a very rare disease process. It's few and far between that we have people that have true expertise in carcinoid heart disease. I think a lot of people have expertise in cardio-oncology, which means that they have expertise in managing the complications of cancer treatment. And they may have some expertise in carcinoid heart disease. But the reality is the number of people in the country that have true expertise in carcinoid heart disease is few and far between. I would ask your cardiologist, how many patients with carcinoid heart disease have they managed before? How comfortable are they with managing this disease process? And if you don't have someone locally that has experience managing carcinoid heart disease, to consider going to a center that has expertise managing carcinoid heart disease. And various, centers that have expertise managing carcinoid heart disease, we try not to make people come back for every single test every single time. And we try to work with the local cardiologist to provide them with the expertise that they need, provide them with the guidance they need, and really work in a collaborative way. So, if you don't have a local cardiologist with expertise in carcinoid heart disease, consider going to a center that has expertise with carcinoid heart disease, and consider making sure that your cardiologist is comfortable with collaborating and working together with them to get you the best outcome possible.
Thank you. That's a very, very helpful to kind of think about, your whole big picture team and how it can best serve you.
Absolutely. And, collaboration is key, especially where you don't have local expertise.
Mm-hmm. And thank you for what you're doing to also educate and spread the awareness about this, as we saw at LACNETS as well. Yeah.
Thank you very much, Lisa.
There's this interesting question about by what mechanism can metastatic midgut NET affect the heart tissue in the absence of liver involvement?
That's a great question, because generally speaking, we expect that a midgut neuroendocrine tumor is first going to metastasize to the liver. Yes, it may also metastasize to lymph nodes locally, but generally, by and large, when we think about metastases from the midgut, all the blood from the gut drains through the liver. And so that's why the liver really is the main site of metastatic involvement. If we're talking about, lymphatic lymph nodes here as the site of metastases, it really depends on how much of a burden there is and how much of that hormone is re-entering the blood circulation through the lymphatic system, which is separate from the blood system of drainage, but the lymphatic system eventually joins the blood system. So by and large, when we think of metastatic neuroendocrine tumor, we generally expect that it's going to have, for the midgut, going to have liver involvement, and then that subsequently causes carcinoid heart disease. But if it was purely be non-metastatic and you have carcinoid heart disease, it would have to have a fairly large burden of tumor that's somehow able to bypass the liver, which would be very, very, very uncommon.
Okay. We're going to end with this last question, and thank you for all the questions you've covered. I think we've covered more than 30. What are the latest or future advances in carcinoid heart disease that you're excited about?
So I think, the things that I'm excited about here are really, as we mentioned earlier, the telotristat study really comes to mind. I think, if that is something that does change outcomes and does alter prognosis, I think that would really be a game changer. But really, at this stage, it's too early to make any recommendations regarding that. And I would hope that in the near future, we would have results for that particular study. From a heart disease point of view as well, cardiology in general, and not particularly in the carcinoid heart disease space, but in the valvular heart disease space altogether, is advancing more and more technologies that we can do without opening the chest up and are able to replace valves through the groin. By and large, I haven't seen this be a successful procedure because of the anatomy or because of the way the tricuspid valves are in carcinoid heart disease. But I think over time, we will see more ability to implant valves through the groin. Generally, at the moment, that's reserved for those people that have had previous surgical valves and in research trials for people that have their own valves. But I think that space will advance and really advance the future of carcinoid heart disease. And then I know my oncology colleagues are working very hard to change prognosis and outcomes in neuroendocrine tumors and really working in collaboration with them to improve outcomes and improve tumor survival as a whole is really another thing that I'm excited about in the carcinoid heart disease space overall.
Thank you so much, Dr. Lewis. We received a comment from a giant in the field, Dr. Jerome Zaks, who said, "Excellent presentation, so helpful." And with that, I want to thank you again, and I am going to turn it back to Heather in the studio.
Thank you.
Thank you again, Dr. Lewis, for your important and illustrative presentation and for answering so many important questions from the audience. We appreciate our supporters, Ipsen, ITM Pharmaceuticals, Tercera, and Crinetics. Again, educational programs like today's are made possible by donors like you as well. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. If you registered for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey as it helps us with event and fundraising planning. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @LACNETS. And now back over to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us for today's educational event. We look forward to seeing you next month. Goodbye.